Good evening, everyone, and welcome to the 14th Masterclass of Jaipur Surgical Tutorial. For those of you who are joining the Masterclass for the first time, just a brief introduction about Jaipur Surgical Tutorial. It's an online education portal that we started at the Mahatma Gandhi Medical College and Hospital about 3 years ago. This is being looked after by my colleague, Dr. Anand Nagar, who's an associate professor of HPB surgery and liver transplantation at my hospital. In the Jaipur Surgical Tutorial, we conduct an online class every Saturday morning, 9 to 10 India time, where students, mostly MCH students in surgical gastroenterology and HPB surgery and DNB students, they present a case. Sometimes they discuss an operative surgery procedure. And from time to time, we have invited lectures by the JST faculty. So this is done every Saturday, 9 to 10 a.m. If you want to join Jaipur Surgical Tutorial, in between the sessions, I will project a slide which will show you how to do that. You can send a WhatsApp message to Dr. Anand Nagar, and then he will add on your name and your contact details to the Jaipur Surgical Tutorial group, which already has more than 500 members, including faculty and students. Then sometime last year, we started these master classes, which are once in a month, and now they will be held every Wednesday and Thursday, last Wednesday and Thursday of the month, so that we don't clash with the IASG Friday evening academic activity. These are done 7 p.m. to 9 p.m. India time. We select one topic or one theme, and then we invite colleagues from all over the country to contribute. Usually, we have 3 presentations on each day, which are half an hour. So the speaker gets about 15 minutes. The moderators have 5 minutes to make comments, and 10 minutes are for question and answer. I would request the moderators that if there are no questions, the questions will come on the YouTube where the delegates are watching this, which I will transmit to the moderators. But if there are no questions from the students, I request the moderators to generate their own questions and carry on the discussion. All the previous master classes, 13 master classes, and all the more than 200 video recordings of the Jaipur Surgical Tutorial sessions are available on the YouTube. All this technical support is provided by the team of my former student and now a colleague, Dr. Avinash Nak at Dwarika Clinic in Ahmedabad. So if you go to YouTube and put Gastro University, which is the name of the online portal which Avinash has started, you will get to the previously recorded videos of all the master classes, all the Jaipur Surgical Tutorial classes, and also the 3 Jaipur Surgical festivals that we have held in the last 3 years. I will make an announcement about a 4th one also, which is going to be held in December this year, and an IASGO postgraduate course on jaundice. So all this educational material is available for free on YouTube for any of the students. So today's theme is carcinoma of the rectum. And to moderate this session, I have invited 2 of my colleagues, Dr. Ram Daga, who was a fellow with us at SGPGI, but now he is a colleague. He is the head of the Department of Surgical Gastroenterology at the SMS College in Jaipur, one of the largest and one of the oldest medical schools in the country. And Deeksha Kapoor, who is a consultant GI surgeon at BLK Max, where she shifted recently from Vedanta, where she had a long innings. And it's very happy to see that today's masterclass is seeing the girl power. We have Deeksha, we have Sharvari, we have Sanyukta. So Deeksha and Sharvari are role models for girls who are doing surgery and who want to do GI and HPB surgery. So with that brief overview, I would hand over to Ram and Deeksha to continue to moderate the session.
Yeah, thank you, sir. So today we are having session on carcinoma rectum, and our first speaker is Dr. Sharvari Pujari. She is from Mumbai, and she will speak on surgical anatomy of rectum. Over to you, Sharvari.
Thank you, Dr. Kapoor, sir. Thank you, Dr. Ram, and hi, Deeksha. My screen is visible.
Yeah.
So I will be talking on the surgical anatomy of rectum with relevance to especially carcinoma of rectum. So the rectum extends from rectosigmoid junction to the anorectal ring. Intraoperatively, the upper margin of rectum can be identified as the level where tinea coli of sigmoid colon diffuse to form a longitudinal layer of rectum and epiploic appendices disappear. This corresponds to the level of about 12 to 15 centimeter from the anal verge, and in the sacrum, it corresponds to about sacral promontory, that is the level of S1 to up to S3 level. It extends from the lower margin of anorectal ring, which is the where the levator ani, all the muscles which form the levator ani, that is the pubococcygeus, iliococcygeus, and puborectalis, merge to form the sphincter complex of the anal canal. That is the lowermost extent of the rectum. So there are some important landmarks when the rectum anatomy is considered. It is considered to be divided into three parts. So if we consider anal canal length as 4 centimeters, then above that in the cranial direction, up to 8 centimeters is the lower third of rectum, from 8 to 12 is the middle third, and from 12 to 16 is the upper third of rectum. It has 3 curves, 2 convex on the right side and middle one convex on the left side. These are important for insertion of the scope. When the scope is inserted, most important or prominent thing which is seen first is the presence of Houston's valves, which are the horizontal semilunar permanent mucosal folds in the lumen, which correspond to the concavity of the curves. So on digital rectal examination, if we consider our length of finger is about 7.5 to 8 centimeter, then it reaches up to middle third of the rectum. Whereas the standard proctoscope, which has the length of 13 centimeter, will show upper part of rectum also. It is also important to know relevant anatomy of the anal canal, as it lies in very much approximation, and it is very much important when the cancer is involved in the lower third of the rectum. So at the anorectal junction, the rectum ends and the anal canal starts. Thereafter, there lies a zone of anal transition zone, and there are the anal columns of the anal glands and the mucosal folds, at the end of which there is the dentate line. So the surgical anal canal, or the anal canal, what surgeons consider, extends from the dentate line to anal verge, whereas the anatomists consider it as from anorectal junction to anal verge. Now coming to peritoneal reflections. The rectum is covered with the peritoneum. In the upper 1/3, the peritoneum is covered anteriorly and laterally. In the middle third, however, it is covered only anteriorly, and the lower third is completely devoid of peritoneum, or it is extraperitoneal. The location of peritoneal reflection, so the peritoneum which comes in front of the rectum gets reflected on its own, and it is known as peritoneal reflection, and this level corresponds to up to about 6 to 9 centimeters from the anal verge. It corresponds to the middle rectal valve, and it is the important landmark as far as resection anastomosis in these regions are considered. Broadly speaking, whatever resection and anastomosis is done above this level of peritoneal reflection is called as anterior resection. Anything below the level of peritoneal reflection is called as low anterior resection. And if the anastomosis go below the level of anorectal ring, then it becomes the ultra low anterior resection. Also, the importance of these rectal divisions is because the upper rectum, oncologically, upper third of the rectum, which is intraperitoneal, oncologically behaves like carcinoma rectum. So it is also treated like carcinoma rectum, broadly considering as broadly it can be remembered as upfront surgery is done when the carcinoma is involving upper rectum. Whereas
sorry to interrupt, you meant carcinoma, it behaves like carcinoma of the colon.
Yes, carcinoma of the colon, sigmoid colon.
Yes.
This is in broad terms. When there is upper rectal or at the rectosigmoid junction, upfront surgery can be considered like we consider in the case of CA colon. When the cancer is in the extraperitoneal part of the rectum, however, because there is no peritoneal covering, the tumors tend to be more aggressive, invade mesorectum more aggressively, and surrounding structures also. These tumors are bulky, and so these require neoadjuvant chemoradiotherapy as a in broad terms, which we will discuss later on at various levels what is to be done. But if it is in the middle, if it is below the level of peritoneal reflection, neoadjuvant chemoradiotherapy comes before the surgery when the management is considered. Also, for the lower third or the distal most rectal cancers comes the importance of sphincters of anal canal, because it is in the close proximation of the sphincters. So here the sphincter saving becomes important consideration, and it is possible only if the lower edge of the tumor is more than 3 centimeter above the anorectal ring. This is because 2 centimeter distal mural margin is considered adequate when rectal resections are done for rectal cancer. When there is neoadjuvant chemoradiotherapy is given, 1 centimeter margin is considered adequate. However, this 1 or 2 centimeter is achieved only if the tumor is above at least 3 centimeters the anorectal ring. Now coming to mesorectum. This is an important structure. It is the fibrofatty tissue that contains the rectal vessels, nerves, and lymph nodes. Posterior to the rectum, the mesorectum lies majoritarily on the posterior side, but it extends laterally also and includes about 3/4 of the circumference of the rectum. And in the most distal parts of the rectum, the mesorectum disappears. The mesorectum is covered by the fascia propria of the rectum, or the visceral fascia, what we can also call it as. Importance of the mesorectum is that the oncological plane of dissection while doing surgery for rectal cancer should lie outside the fascia propria, preserving intact mesorectum. Means we have to resect the rectum, mesorectum as an intact unit, with the plane of dissection being outside the mesorectal fascia, the fascia propria. Now coming to these facial relationships. So the fascia propria is the fascia which covers the mesorectum. The parietal pelvic fascia covers the bony pelvis and covers the sacrum, coccyx, and muscles of the pelvic side walls, and so it covers the presacral veins. It is the lateral most structure in the pelvis. These two fascia fuse posteriorly at the level of S4 to form the rectosacral fascia, which needs division in the low anterior resection surgery. Whereas anteriorly, this visceral fascia is reflected on the prostate as a denonvillous fascia in men, or as a rectovaginal fascia in females. These visceral and parietal endopelvic fascia can be considered as downward extensions from the abdomen. So the visceral fascia is the one which is lying anterior to the vessels, retroperitoneal vessels, that is aorta and vena cava, and then it extends in the pelvis and envelopes the rectum and becomes visceral endopelvic fascia. Whereas the parietal fascia is the one which lies posterior in the abdomen, posterior to the vessels, aorta and cava, and thus runs along the pelvic wall and covers the bony pelvis and the muscles of pelvis. So there is a potential space which lies in between these two fascia, which is devoid of any neurovascular tissue, but it is only filled with loose areolar tissue, and this is the important plane which is described as holy plane of Head, which is of the utmost importance in the total mesorectal excision. Now, below the level of peritoneal reflection, rectum is supported by the lateral rectal ligaments. These lateral rectal ligaments are the extraperitoneal thick bundle of dense connective tissue, and in this lateral rectal ligaments, they contribute to the support of the rectum, and so they also contain some branches of middle hepatic artery. The main middle hepatic artery usually doesn't travel through the lateral rectal ligaments, but there are branches of middle hemorrhoidal artery, lymphatics, and plexuses. At the lateral most part of these lateral rectal ligaments lies near the pelvic walls, and so beneath these lies the pelvic plexus of autonomic nerves. So without injuring these pelvic plexus, these lateral rectal ligaments should be divided sharply and need ligation because vessels are there and they bleed. And one more important thing is, once these ligaments are divided, it straightens up the rectum, and complete mobilization of lateral rectal ligaments leads to addition of length of about 2 centimeters. So if there is a tumor situated in this crucial position where length or distal margin is an issue, then lateral rectal ligament division may shift the tumor little upwards, that is about 2 centimeter upwards, and that much length and the distal margin can be achieved. Now coming to blood supply of the rectum. Rectum is supplied superiorly by the superior rectal artery, which comes from the inferior mesenteric artery branch of aorta. Middle rectal artery arises from the internal iliac artery, supplying the middle and lower part of the rectum, and inferior rectal artery arises from the internal pudendal artery. Similarly, the veins, the superior rectal vein drains into the inferior mesenteric vein and to the portal vein, which drains the upper and middle part of the rectum. Middle rectal vein will go to internal iliac vein and then to the systemic part, that is the IVC. So these portal vein and IVC communication become important part of porto-venous communication site when the portal hypertension, when the patient is a case of portal hypertension. Inferior rectal vein drains to the pudendal vein, and that also drains the part of the anal canal. Now coming to lymphatic drainage. Upper and middle part of the rectum clearly drains from the via the nodes along the superior rectal vessels to the first to the pararectal nodes and then to the inferior mesenteric nodes. What happens below the level of peritoneal reflection is that it has a dual lymphatic drainage. So below this level, majoritarily it drains upwards, that is along the superior rectal artery to IMA and para-aortic nodes. However, some part also drains laterally, goes in the lateral direction along the middle and inferior rectal artery, and then go to the internal and external iliac group of lymph nodes. And below the dentate line, it goes to inguinal group of lymph nodes. So why this is important? Because the internal iliac lymph node, these are the pararectal nodes, these are the internal iliac, this is the obturator, these are the external iliac and common iliac group of lymph nodes. So there is no doubt about the internal iliac group of lymph nodes. These are considered as regional disease and will be resected in the standard resections. However, this external group of lymph nodes near the external iliac, common carotid and obturator are considered as metastatic group of lymph nodes according to the Western concept, and TNM also considered it as metastatic, whereas Japanese people considered the same as regional only. So they advocate lateral lymph node dissection. However, in the TNM guidelines, this is to be treated with the chemoradiotherapy and radiotherapy to the lymph nodes. So this group of lymph nodes, which is the common iliac group of lymph nodes, station 273. This is the internal iliac 263 station, and 283, that is the obturator. In between the internal and external iliac vessels is the obturator group of lymph nodes, and this group of lymph nodes is called as lateral lymph nodes or lateral pelvic lymph nodes, and the dissection of lateral pelvic lymph nodes during standard rectal carcinoma surgeries is a matter of debate. As I said, majority of the lymph node metastasis, that is up to 40%, goes to superior group of lymph nodes, and only 15% of the times these lateral lymph nodes are involved. But the advantages of lateral lymph node dissection is proposed that it decreases the intrapelvic recurrence by 5% and improves 5-year survival by 8 to 9%. However, the opponents say that as it is involved in only small percentage of cases, why to add the operative time and thus put the patient to higher morbidity. Besides this, they consider lateral lymph node, involvement of lateral group of pelvic lymph nodes is the indicative of systemic disease. Now coming to nerve supply, the rectum has both sympathetic and parasympathetic nerve supply. The sympathetic comes from the lumbar splanchnic, which is responsible for relaxation of, in broad terms, it is responsible for rectal muscle relaxation and contraction of sphincters, whereas parasympathetic allows stools to pass, that is contraction of rectal walls and relaxation of internal anal sphincter. Besides this, some important plexuses which are there in this region are the superior hypogastric plexus and inferior hypogastric plexus. So superior hypogastric plexus arises near the aortic bifurcation and near the origin of inferior mesenteric artery. It contains the sympathetic fibers majoritarily. The lowermost extension of the superior hypogastric plexus descends down as hypogastric nerves, and then it goes into the pelvis. So high IMA ligation or ligation of IMA flush to the aorta leads to damaging of the superior hypogastric plexus, and whereas when the dissection is there in the pelvis, the pelvic plexus, which is also called as inferior hypogastric plexus, is encountered. It is present along the lateral walls of the pelvis, and it gives fan-shaped fibers to innervate the urogenital organs. It contains both sympathetic and parasympathetic fibers. So this is the IVC and aorta, and in front of L3 originates the superior hypogastric plexus with its ganglion, and then it descends down in the near or lateral to the aorta, and this is the origin of IMA. So when the IMA is ligated and divided flush to aorta, there is a chance of injuring the superior hypogastric plexus. When it descends down in the pelvis, they become hypogastric nerves. These are the hypogastric nerves on the right and left side. These are lateral to the midline and medial to the ureters, which cross the iliac vessels. So our dissection should be medial to the hypogastric nerves, pushing all the structures of hypogastric nerves, ureter and iliac vessels posteriorly and laterally without injuring them. So as I said, the hypogastric nerves descend in the pelvis and ureters cross over the iliac vessels but lie lateral to the hypogastric nerves on either sides. So the inferior hypogastric plexus lies on the pelvic side walls and then gives fibers to the urogenital organs. This is the plexus of the uterus, going to the uterus, and then the nerve to the urinary sphincter. The nerve to urinary sphincter arises in the groove between the rectum and levator ani muscle at the level of pelvic floor, and is likely to get injured when the levator ani is divided during APR. So once again I am repeating, this is the ligating IMA pedicle, and this is the superior hypogastric plexus. This is the mesorectum. These are the hypogastric nerves, and this is the pre-hypogastric nerve fascia. So the dissection should be just behind the rectum, pushing this fascia and nerves posteriorly. On the right side, it should be in the triangular area anterolateral to the right hypogastric nerve towards the mesorectum, and not here. This star area, the dissection should not go in this region on the right side. In the inferior, so the inferior hypogastric and plexus and the nerves are preserved, and anteriorly it should be, the neurovascular bundle should be pushed anteriorly towards the prostate. I would like to show the same in this small video. I'm sure it will be also talked about during the surgical session tomorrow. But this is during the dissection of aorta, this IMA is lifted up, laparoscopic LAR is being done, and this is the nerve plexus, superior hypogastric nerve plexus lying on the aorta, and so the IMA is divided approximately 1.5 to 2 centimeters beyond its origin. This is in the region of hypogastric nerves. The dissection is being done in the pelvis, and the hypogastric nerves will be lying posterior. This is the mesorectum, and this should be the line of dissection. Pushing the nerves behind. When the dissection is on the lateral wall, this is the left side of the dissection. This is near the pelvic wall, but without injuring the pelvic plexus line here. And then the dissection is continued anteriorly. And the pelvic plexus, you can see here the nerves of the pelvic plexus running laterally on the pelvic wall and giving fibers in the fan-shaped manner, and then running towards the bladder and the genital organs. In the anterior, this is the on the right side, this is the right hypogastric nerve, which I showed you in the picture. This is the nerve. And if there is excessive traction, the nerve gets tented and it gets pulled towards the mesorectum. However, and then there is a chance of injury to the right hypogastric nerve and the plexus. So, but there lies a triangular area, and the dissection should be pushing the nerve and plexus laterally, like this. This is the right hypogastric nerve, and the line of dissection should go just near the mesorectum. And then this is the anterior dissection. If the tumor is placed anteriorly on the rectum, it becomes more difficult to push the neurovascular bundle anteriorly from the denonvillus fascia. As denonvillus fascia is opened, and the neurovascular bundle is pushed in all cases. But if the tumor is placed anteriorly, there is high chance that the injury may happen. This is at the level of pelvic floor. So these are the 4 important sites where there is the likelihood of nerve injury. So if there is injury of the superior hypogastric plexus, the symptoms can be retrograde ejaculation and dyspareunia, because majority of the nerves are sympathetic. So parasympathetic overactivity will happen. In the hypogastric nerve is injured, if the hypogastric nerve is injured, there will be symptoms of urinary problems in the form of neurogenic incontinence or atonic bladder. In the case of inferior hepatic plexus injury, impotence will be there and urinary dysfunction. Here the parasympathetic nerves are will get injured, and it will lead to erectile dysfunction. Whereas if the nervy irrigants are injured, again there will be voiding issues or impaired vaginal lubrication. Now coming to in short about the TME, something about TME. So the TME is the removal, total mesorectal excision is the removal of entire mesorectum, including posterior and portion distal to the tumor, keeping intact, keeping the fascia intact. It should be in correct plane, that is the holy plane. There should be sharp dissection, intact mesorectum, and 5 centimeter distal to the tumor margin. The mesorectum is supposed to be resected, with distal mural margin is advised is 1 centimeter at least, and the CRM should be at least 1 millimeter. So what is the CRM? It is a circumferential resection margin, which is the non-peritonealized surface of the rectal specimen created after mesorectal dissection. This is the main cause of local recurrence when the CRM is positive. And if it is considered positive, if it is less than 1 millimeter, that means the distance of the tumor or the tumor deposit, the distance from that margin to the closest margin of the surgical resection, non-peritonealized resection margin, is considered as circumferential rectal margin, and it should be at least 1 millimeter or more. If it is less than 1, there is enough literature to suggest that if there is a less than 1 millimeter margin, the local recurrence rate is very high. It goes up to 22% compared with only 5% if the margin is more than 1 millimeter. And also if margin is positive, along with local recurrence is also there is also increased risk of distant metastasis and shorter survival. Coming to surgical options of rectal cancer, when there is upper third, it is clear that anterior resection can be done. When it is the lower third, below the level of peritoneal reflection, then it is called as low anterior resection. The anastomosis goes below the level of peritoneal reflection. And for the lower third, there are few more options depending upon the Ruhlier's classification. So low anterior resection is possible if the tumor is located 5 centimeter or more from the dentate line, so that at least 1 to 2 centimeter distal margin is achievable, and the anastomosis will be colorectal anastomosis done by double staple technique. If the tumor is further below, that is within 1 to 2 centimeters of the dentate line, then only then the appropriate margin will be reached only if the anastomosis is done at the level of anorectal ring, where the anastomosis then will be coloanal anastomosis. Colon to anal canal anastomosis will be there, which may require hand seven anastomosis, and then it is called as ultra low resection. If the tumor is further below this level, which involves the internal anal sphincter but spares the external anal sphincter, then we need to resect the internal anal sphincter either in, so it is called as intersphincteric resection, and it can be a partial intersphincteric resection, subtotal or total, depending upon the level of involvement. Upper 1/3 up to 2/3 of the internal sphincter is resected in the subtotal, and complete resection of internal anal sphincter in the intersphincteric groove is done if we have to do a total intersphincteric resection. Now, if the tumor is involving the external anal sphincter also, then both the internal and external anal sphincters are supposed to be excised, and then the patient becomes a candidate for abdominoperineal resection. The sphincter cannot be saved, and patient has to undergo abdominoperineal resection. Conventional abdominoperineal resection was used to be done like this without taking the levator. So the specimen used to be conical in shape with a vest lying at the tumor level, increasing the chance of CRM positivity. So extra levator APR should be done, which removes APR also, giving a cylindrical type of specimen and minimizing the chance of CRM positivity, and even further modifications of this in the form of unilateral hemi levator ani resection or many things like this are described. Thus, to conclude, the rectum has the dual arterial blood supply, dual venous drainage, extensive lymphatic drainage. It is located in the, in fact, 3 arteries, 3 veins, and the dual lymphatic drainage. It is located in the bony pelvis surrounding the various important urogenital and neurovascular structures. The surgical treatment of the rectum is challenging, which is the total mesorectal excision as the standard of care. And to achieve this, good and thorough knowledge of the surgical anatomy of rectum is of paramount importance. Thank you.
Before I hand over to the moderators, there's a question on YouTube, although it's not related to topic, but Sharvari, if you can quickly answer this. Himanshu Mishra wants to know, while doing pouch surgery for ulcerative colitis, what is the level of distal transaction of rectum? Is it the levator ani level or is it dentate line?
The pouch surgery, Himanshu, the pouch surgery itself describes the name. The name of the pouch surgery is ileal pouch anal anastomosis. So the entire rectum, it is done for the ulcerative colitis. So when the rectum is involved, and usually it is involved in the ulcerative colitis, so the entire diseased portion of the rectum is supposed to get resected. Here we do not resect the anal transition zone, but do the anastomosis just above the level of anal transition zone, that is at the anorectal ring level, and it will be a ileal pouch to anal anastomosis, keeping sphincters intact.
Over to you, Ram and Deeksha.
Dr. Sharvari, thank you. That was a brilliant talk. I think you covered all aspects of the surgical anatomy of rectum very relevantly.
Thank you.
Before I pick up a few questions with you, I really want to thank Dr. Kapoor sir for involving me once again for the master classes. It's always a privilege, and you've always been very kind and encouraging. So just to add to Himanshu's question, when we are dissecting from above and from inside, the landmark is the pelvic floor or the levator and eye muscles where they start becoming vertical. And when we are doing a perrectal from inside or visualizing the disease from inside, it is the dentate line. Actually, it almost coincides by hardly any difference. So it's probably one or the same things. Sharvari, I want to ask you that during surgery, how does a beginner differentiate between the fascia, between the various layers of the TME while doing the TME?
Okay. So if the TME in the open as well as in the laparoscopy, I will describe it more in the TME, laparoscopic low anterior resection. So when you lift up the colon, you retract the sigmoid colon and lift up the rectum, the plane which is there can be seen as a white line, and if you are in the correct plane and if there is incorrect insufflation, then the planes get clearly defined when the gas goes in. But if there is no laparoscopic surgery, if it is an open surgery and the rectum is retracted, and so it is a matter of proper retraction and finding the plane. So if the rectum is pulled anteriorly and superiorly, then behind the rectum and mesorectum, just in front of the vessels, we get a plane. When we start the surgery for rectal cancer, we usually start at the level of IMA. So a vascular pedicle gets lifted up and becomes taut and looks like a cord-like structure where we can identify the inferior mesenteric artery and vessel. And the plane below that, the level below that, if we start dissecting, then we are actually in the proper plane, which is confirmed from the other side also. From the lateral side, it starts from the division, after the division of ligament, line of Told.
Yes, that's very beautifully described, Dr. Sharvari. I just want to add to it that when we pinch at the sacral promontory and just lift the rectosigmoid junction superiorly to the left and towards the anterior abdominal wall end of the patient, and just with a little bit of scoring on the peritoneal surface, a shiny sheath gets separated towards the side of the mesorectum. One sheath gets left behind, and there is a crisscrossing of fibers which need to be divided. So if the fat is being breached, that means we are too much towards the rectum. The fat should belong to the rectum. So that's, I think, one point that we need to emphasize on surgical anatomy and the surgical technique, that the fat always belongs to the rectum.
Yes.
Dr. Ram, you want to add something to this?
I would like to ask a question.
Yeah, please.
Yeah. So, what are the importance of these various fascia? Walden's fascia, rectosacral fascia, lateral ligament, condensation of these fascia? What is the importance on surgical table as such? How they make your surgery difficult or easy, or in what way they change your surgical plans?
Yes, so the basic for the total mesorectal excision, we have to identify the visceral fascia or the fascia propria, and it has to come along with the mesorectum, and our plane should be behind that. Then only we will enter, as we discussed just now, into the plane of holy plane of head, where there will be no neurovascular structures. Another important thing is that we don't have to breach the fascia which lies behind that, because it is the presacral fascia, and behind the presacral fascia will be the neurovascular bundle. There will be presacral veins which will bleed terribly, and which will be very difficult to control the bleeding from the presacral veins, because these are the veins which come from the sacral foramina, and they bleed and they get retracted inside the sacral foramina. So important thing is not to breach the presacral fascia which is covering all these structures. Now these two fascia, when we go below and below at the level of S4 and coccyx level, form the rectosacral ligament, and that needs to be divided if our dissection goes there sharply. Division of coccyx or excision of coccyx may or may not be done, but division of the rectosacral ligament is a must if the surgery is in the low AR or ultra low AR region. Anteriorly, the fascias are important because it is the facial reflection on the prostate or the in the female's rectovaginal septum. So the dissection should, the denonvular fascia should be opened. The fascia should come with the rectum. However, the neurovascular, again the venous plexus which lies below the covering, the fascia is covering the venous plexus, and that should not be breached. So even in some cases, if the lesion is posterior or if the lesion is little higher up, then even denonvular fascia can be left behind the prostatic venous plexus. But if it is required to be excised, then the venous plexus must be taken care of, must not be injured.
I think we
what will you explain to residents?
Besides
Yes,
this, whenever there is anastomotic, besides this, in the case of any benign diseases, or if there is a rectal perforation, or if there is a rectal leak, if it is in the extraperitoneal region, then it can be managed extraperitoneally from the perineal side. If it need not be there need not be any the laparotomy if the perforation is in the extraperitoneal region. It remains contained in the extraperitoneal region and the peritoneum is clean if there is a small leak or perforation in the extraperitoneal side.